Hello everyone and welcome to IJCCM Editor Spotlight, a series where we go beyond the published manuscript and speak with the authors behind some of the most impactful research published in Indian Journal of Critical Care Medicine. It is my pleasure to welcome our Editor-in-Chief, Dr. Jigishu Divatia, and Dr. Subhash Todi, the primary author of the landmark Guideline. Thank you for joining us, and over to Jigi sir.
Thank you, Gunjan.
Thank you, Gunjan, and hello everyone. The Editor's Spotlight is a series where we will focus on some of the major articles that have been published in the IJCCM and will feature author interviews. And I'm very, very happy to say that this time we've got an excellent IJCCM guideline on the treatment of carbapenem-resistant gram-negative organisms of various sort of species, classes. And the lead author of this guideline was Dr. Subhash Todi, and we will be speaking to Dr. Todi today about the inside story to his how the guidelines were developed. But before we sort of take off on this spotlight interview, I am extremely pleased to inform all viewers that the Indian Journal of Critical Care Medicine has now received an improved impact factor, which is 2.0, and which is good. And I would sincerely encourage everyone to contribute the best research and their work to the Indian Journal of Critical Care Medicine. So over to Dr. Gunjan, and let's start with the spotlight interview with Dr. Todi.
Thank you, sir. So let's begin with talking about the journey behind this important work, sir. Could you take us back to the beginning? How did this project come about and what inspired you to develop these guidelines?
Thank you, Gunjan. The project started when I was the guideline committee chair of IJCCM during the tenure of Dr. Pradeep Bhattacharya as the president and Bharat Jigyasi as the general secretary. We had good guidelines from IJCCM prior to this. During Dr. Sheila Maitra's tenure, there were quite a few guidelines published in IJCCM. But when we looked at them, most of them were either position statement or narrative review on a very broad subject. So we thought that let us do what has been done internationally and by very big societies. And the thing that what we did different in an Indian guideline were two things. One was it was a very focused guideline rather than guideline on gram-negative infection, which focused on carba-resistant gram-negative infection. So very focused guideline. And second was the question which was important to us and in the Indian context. So these were the two main principles, that we should have a focused guideline and we should have questions based on what is the Indian clinical context. So that's how the journey started. So we selected few topics and then we went about it. Over to you.
So Dr. Todi, you have used the GRADE methodology. And you mentioned that you did not want a narrative review or just a synthesis of opinions and so on. So you have chosen the GRADE methodology, which is an internationally accepted and highly respected way of going about things. So, and there are other methods as well. So why did you choose the GRADE methodology? And what was the experience? And you also collaborated with Dr. Bram Rochberg, who's one of the leading authorities in the. So can you tell us about why you chose this approach and how was your experience working with the leaders in this field?
GRADE has been well accepted by universally, even by Cochrane and many other big societies. And it's a very well established way to synthesize evidence. And since we had help of Dr. Bram, whom we had Zoom meetings at very odd hours of his odd hours in the morning, 5 o'clock. So we were really happy to have him on board. So that was one of the main reasons. The second was the methodology was applicable to whatever evidence we had to the question that we had in our mind. though we had obstacles and problems on the way that I would like to describe of how to implement this grade methodology. And in the grade methodology have level of evidence and grade of recommendation. When it came to level of evidence, we knew almost even prior to starting these guidelines that the evidence is not going to be very strong because of this carba-resistant infection is not very common in Western countries, and that's what we found. But then we had to give recommendation. So we had this panel which we discussed among ourselves. We looked at 4 things. We looked at clinical cure, microbiological cure, adverse events, and mortality. And in most of the studies, there was no difference in mortality. But if there is a strong trend towards better clinical cure, better microbiological cure, and less adverse event, we thought that we should be giving a strong recommendation, even if there is no improvement in mortality. So there was some tweaking of the recommendations and the level of, depending upon the level of evidence. Over to you, Jiggy.
Sir, every guideline starts with asking the right questions. So how, as a panel, do you identify and prioritize the PICO questions that help you shape these recommendations?
Nowadays, this PICO, the patients were very clear. Since we had a very focused guideline, we had to have patient who had a carba-resistant infection. Then we identified 3 infections which we should be focusing on, which were very common in our country. Carba-resistant Enterobacteriaceae, that is E. coli Klebsiella, carba-resistant Acinetobacter, and carba-resistant Pseudomonas. So we thought that we'll focus on these 3 bacteria, and the intervention was, since use of polymyxin and colistin was very prevalent in India, even now, so we thought let us do that as an intervention. And comparator was any antibiotic which is non-polymyxin or non-colistin based therapy. And the outcome, as I mentioned, were those 4 outcomes: mortality, clinical cure, microbiological cure, and adverse event. The last element in PICO nowadays is T, which is the time. I will rather phrase it as tricky. The T is very tricky. The time frame is, especially this was our first endeavor. And even if you look at IJCCM, who took great guidelines for their latest iteration of their guidelines, it took them about 1.5 to 2 years to complete the entire process. And that's what we took as well. It started in 24-ish, mid of 24, and that's how, so it takes time. But over time, we are learning the process. So hopefully the next group of people will find it easier to adopt this technology and adopt this methodology and make more guidelines. So apart from these PICO, keeping on the MDR, we had nebulized colistin versus systemic antibiotic only without nebulized colistin on the same 3 organisms, which we have completed, and we have submitted it to IJCCM for peer review. We had 2 other PICOs which are still in pipeline. We have not yet started. One is monotherapy versus combination therapy on these 3 organisms, and what would be the duration of antibiotics, because all the studies on duration of antibiotics is done in non-resistant, non-carba-resistant infections. So we don't know what is the optimal duration. So we have to look at the literature, see what were the outcomes and what were the different duration of antibiotics were given to these patient populations. So these 2 are still pending, but one is it with Dr. Jiggy for review. Over to you, Chanchal. Gunjan.
So, Dr. Todi, this was a mammoth exercise, right? It's taken you almost 1.5 years. Just to give our readers and us some idea of how much work you did, how many manuscripts did you screen? Then how many did you evaluate thoroughly? And finally, how did you get down to distilling all that information into a manuscript? It is a long manuscript. It's almost 40 odd pages, but very nicely done. Lots of tables and figures and lots of information. But how many manuscripts did you actually go through, you and your team?
It was a teamwork. So for these three bacteria, we had three groups. For Enterobacteriaceae, there was one, and each group had around 5-6 panelists. For Acinetobacter, there was one. Pseudomonas, there was one. And what we thought that the first thing was to pick up the keywords. And that was the key problem, I would say. So people had the different panelists suggested the keywords. And we also took help of expert people who are very expert in this search criteria, methodology criteria. We had Dr. Medha Joshi, who was ex-Tata Cancer, you know her well. So she also helped us. So we picked up the keywords. But looking back, probably our next iteration, this is something where AI might have helped us in picking up what are the right keywords, because we can't be too specific and we can't be too sensitive. If you're too sensitive, you'll have thousands and thousands of articles. And if you're too specific, you will lose many important articles. So I think that is something. So we picked up around 8 or 10 keywords under each domain. Then we gave it to our search specialist to look into. So the first obstacle that we had here was, what kind of a platform are we going to search? So PubMed was the one which was available for us, and we searched it from 2000 to 2024. The other ones were paid, though IJCCM did give us the budget, but to have that paid platform was very difficult. So there were 2 or 3 like Embase and other, they are paid platforms. So we had to restrict our search. Even Cochrane search was a paid platform. So we had to restrict our search to PubMed only. So once we have restricted our search to PubMed, we had around 4,000 articles of all the three together, just the titles and the abstracts. So each group just went through the titles and the abstract, and that itself gave us an idea that which are the articles that we should retrieve full text. So at the end, we had landed up having around 100 full text articles out of this 4,000 titles and abstract, which we thought could fulfill our PICO criteria. There again, we got an obstacle, how to get the full text, because some of these full texts were from the paid journals and we were not able. So we went through our different panelists who had access to different journals and all. So that was the second obstacle that we had, is to get the full text. So out of that 100 full text, which was divided among these three groups, so each group had around 20 to 25 full text to read. Ultimately, we boiled it down to around 50 full text articles, which we thought of RCTs, observational studies, which we thought would fulfill the PICO criteria. And then those were analyzed as per the grade methodologies, and those were the ones where we had the reference in the articles. So that is how this flow sheet went through. Over to you,
just a quick aside. We mentioned that carbapenem-resistant gram-negatives is an Indian problem, and but how many of these references articles did you get from India, and how much literature was from other countries?
90% were from other countries. Like they also have like Greece, Spain, Italy, were from there. There were few guidelines, like there is an European guidelines on similar. So, but they did not concentrated on carbapenem resistant. Most of them, apart from very few, those were also observational studies from India. I would say you can count on fingers, around 8 to 10 were from India, which were included. That also gave us an insight, but those were observational studies. Over to you.
So one of the strengths that you mentioned, sir, is its relevance of these guidelines in the Indian practice. So did you take other factors like affordability or availability of antimicrobials and the resource limited settings that we have, did they influence your way to how you created the recommendations or formulated them?
Yeah, so far as the evidence is concerned, grade has level of evidence and strength of recommendation. The level of evidence, for example, give an example, sulbactam, durlobactam as a therapy of choice for Acinetobacter. We do not have that in India. But if you go through the evidence, that's the best evidence that we have for Acinetobacter. So what kind of recommendation can we give? Just because it is not available today in India, can we give it a weak recommendation where there is a mortality benefit of sulbactam, durlobactam? It might be available next year, we don't know. So I think that's why we gave it a strong recommendation. So I think it depends upon if the level of evidence is very strong, even if that is not available just now, or even if the cost is high, it is a very heterogeneous health system we have. So even if the cost is high, if the level of evidence is very high, I think we should be giving it a strong recommendation. And that's what we followed here. If you look at Acinetobacter, the sulbactam durlo was a strong recommendation with a high quality of evidence. Over to you.
Yes, and yeah, Dr. Todi, I did see in many of your tables and in your figures, you've also included ampicillin, sulbactam, and also, I mean, those comparisons are there. So it's
so what we did was we took the sulbactam based therapy, whatever the literature was there.
Yeah. So I think there is, even like, I entirely agree with you. Even if the drug is not available today, that it might be available, and in some people may be in a position to import it, from somewhere, and so it does give you some idea of what to use and what not to use.
Yeah,
I think that's excellent. Again, just as a follow-up to my previous question, you said there was very little Indian literature on when you did your literature search on carbapenem, even though it's a major Indian problem. So what do you think should be the areas of research as far as India is concerned, and what areas you think we should focus on it, maybe at least as far as this field of antibiotic resistance and so on is concerned?
No, it's time that we have at the present moment the level, if you look at the level of evidence on these therapy in India, it was most of them were single center, and they were just plain observation. These patients grew this and this was the outcome. So yes, I think the gold standard is RCTs and all, but we had experience of RCTs in sepsis all throughout the world. It has not led us to a very robust outcomes. So I think the next level that we should go is to at least have a good protocolized multi-center prospective either registry or a study on these organisms, and have a protocolized sheet and have it prospectively. Record the patient's baseline problems, what was the therapy given, what was the outcome, and covering at least most of the centers, the big and the smaller centers, and having a good microbiological backup so we have a robust diagnosis and look at a robust outcome. So I think that will be the next phase, to have a big prospective multi-center study on these bacteria and what were the outcome on this, given whatever therapies we have at the present moment. For example, when this guideline was made, Aztreonam avibactam was not available in India. So people have been using ceftazidime with Aztreonam. So this guideline did not address that part, Aztreonam avibactam, but now people are using that molecule. So I think this is the next way to go in the coming year or so, having a multi-center prospective observational study headed by a steering committee of experts, infectious disease intensivist, microbiologist, and having a protocolized observation and CRF on that. Over to you.
Congratulations once again, sir, for this enormous task that you have done, and all the panelists. For our viewers who are watching this, could you give us 5 most important take-home messages from these guidelines?
I will just go through the main recommendations of these guidelines. For carba-resistant enterobacteriaceae like E. coli and Klebsiella, there is a strong recommendation now because of these new BL-BLI combinations that we should get away from polymyxin-based therapy. There was better clinical cure, there was better microbiological cure, there was a trend towards better mortality and less adverse effect. So there was a strong recommendation for BL-BLI, of which the second message would be ceftazidime-based therapy. That means, most of the literature, unfortunately, were not from an NDM-rich environment. So they were just ceftazidime. And even ceftazidime showed, but we have a mix, as you know, of NDM and oxa. So probably with or without aztreonam, and aztreonam avibactam in the future iteration we might find. So that was the second message. For carba-resistant Acinetobacter, the literature was rather 50-50 between polymyxin-based therapy versus non-polymyxin-based therapy. Definitely there was no difference in mortality. There was a trend towards a better clinical cure and microbiological cure and less adverse event with non-polymyxin-based therapy. So it was a weak recommendation. The fourth one was the sulbactam-based therapy, and as I mentioned, there was a strong recommendation. If we have a sulbactam durlobactam, even if we don't have it, using a high-dose sulbactam as a backbone therapy for Acinetobacter, for whatever combination we are going to use, would be a very important therapy for carba-resistant Acinetobacter. For carba-resistant Pseudomonas, again, we did not had a very strong evidence for either BL-BLIs. The only one that we had was ceftolozane tazobactam, which is not available in India now. So we did give it a weak recommendation because there is again a trend towards clinical cure and microcure and less adverse event, no effect on mortality of BL-BLIs rather than polymyxin on carba-resistant Pseudomonas. But once we have ceftolozane tazobactam available to us, that might be the drug of choice for carba-resistant Pseudomonas. So these 5 were the key takeaway messages from these guidelines. Over to you.
So thank you, Dr. Todi, for these valuable insights. And I think for that very nice, succinct messages that you gave for that clinicians can take away on how to treat carbapenem-resistant gram-negatives in our setting. And as you very correctly mentioned, some new drugs are likely to be available in the near future, including cefiderocol, ceftolozane tazobactam, cefepime, zidibactam, which is our homegrown antibiotic, and many others. I think the future scenario is not as bleak for gram-negative.
It's a moving field. It's a moving field, and I'm sure we'll be having more. And so I think these guidelines need to be updated every 3-4 years. So the next iteration should be again during that 4 years we should produce our own evidence, I think.
And your idea about having a well-constructed prospective trial or a registry is extremely important, and hopefully the IJCCM will think about this project as they've taken up your guidelines. So I think the future is quite exciting, and I think IJCCM is on the right track, and the IJCCM looks forward to reviewing your manuscript on nebulized colistin and many other guidelines that will become. I am absolutely impressed, and I'm absolutely recommend that people use proper evidence synthesis, whether it's a grade methodology or something, but rather than narrative reviews or just a group of people sitting together, a well-referenced and a well-synthesized document will not only help us better in our clinical management, but will earn the respect of the entire world. And I think that is where India should be going. And thank you, Dr. Todi, for taking the lead in that respect.
Thank you. Thank you, Jiggy. Thank you, Gunjan. Thanks a lot.
Thank you, everyone. Thank you for watching IJCCM Editor Spotlight. I am Dr. Gunjan Chanchlani, Associate Editor and Social Media Editor of Indian Journal of Critical Care Medicine. Until next time, keep reading, keep advancing critical care. Thank you.
Thank you.